It's Memorial Day, 9:31. I'm a minute late, sorry. I'm still trying to figure out if I can share a screen like I do on Zoom when I'm teaching. But I think Facebook has it so that you either have to be live on camera or you can share your screen, but not both. I'm not sure. But I might try that coming up. Hey, Tammy. So one thing I'm going to do, though, is instead of looking down at notes and stuff, I'm going to switch over to different screens. And I think with my camera running, I'll still stay on camera. So what we're going to do is Friday, we talked about antiviral protocols for COVID-19, specifically remdesivir versus Plaquenil with or without a macrolide antibiotic. The one that's used is azithromycin, which is sold in a Z-Pack, it's called. And as soon as I got off Friday, hey Linda, as soon as I got off Friday, a friend of mine on Facebook posted a Lancet article that came out Friday. So I'm going to go through that, and then there's a couple of things I'm going to run through about or from the American Association of Physicians and Surgeons. It's not a statement from them, but some stuff I found out on worldwide treatment protocols that are being used not in the U.S. per se. So most of the United States treatments, hey Dana, most of the U.S. treatments are later in hospitalization. So around actually third world countries, we're seeing people, physicians that are using Plaquenil with or without a Z-Pack as a prophylactic measure. And there's an updated set or site, I guess, that reviews all these little studies, and I've got a link for that. Hi, Eileen. And I'm going to post that in the comments when I get done because it's updated all the time, and it's little, all these little studies going on all over the world. So that you can look at it if you're into science and that kind of thing. So I'm going to switch to a different screen here in a minute, and hopefully I stay on camera. Not that you need to see my face, but I don't know what you would see otherwise, I'm guessing, since my little green dot on my camera is doing okay. Okay, so the Lancet on Friday, May 22nd, right after, I found this like 10 minutes after I got off Facebook Live on Friday. And so this was a multinational registry. And the multinational registry was from 671 hospitals on 6 continents. Okay, so this isn't prospective, it's not randomized, it's not this, it's not that, all the stuff that you keep hearing in the media about why you shouldn't do this and why you shouldn't do that. Hey Linda, hey Kelsey. And so anyway, hydroxychloroquine or chloroquine with or without a Z-Pack is what they looked at. And it had to be started within 48 hours of a diagnosis. So this isn't a prevention type thing or a prophylactic type thing. These are patients around the world that, and they excluded people that started one of these regimens after 48 hours from when they were diagnosed. So presumably a pharyngeal swab, nasopharyngeal swab that was positive. Hey, Abby. Hey, Shelly. And so within 48 hours, they had to start either hydroxychloroquine or Plaquenil by itself, chloroquine by itself, or one of those two with a Z-Pack. So 4 groups, basically. And so if you exclude anybody after 48 hours, they also excluded patients that were on mechanical ventilation. So presumably those were later in a hospitalization. And they compared the groups. And of course, the media was all over this story on Friday saying, well, using these medications may actually kill you faster. And that's basically what their data showed. Hey, Heather. And so the control group, which was much higher than the actual group that were treated, did not receive any of those treatments. Okay, and then anybody that was on remdesivir, which we talked about Friday, was also excluded. Okay, okay, so they're reporting 96,032 patients hospitalized, average age of 53.9, and this is from December 20th, 2019 through April 14th, 2020. And I think by the end of that week, so April 21st, all of those patients had either been discharged, Maureen and Lisa had either been discharged or they had died. Okay, so in the treatment group, those four little arms was 14,888 people, and then the control group, so those were the patients that received neither chloroquine or hydroxychloroquine or azithromycin, was 81,144 people. And of those 96,032 that made the study criteria, 10,698 patients died. The rest of them were discharged. Okay, so here's the numbers, and this is what everybody's fighting about. The control group mortality, so the 81,144 people, their death rate was 9.3%, their mortality, so they died. Okay, in the hydroxychloroquine only group, 18% mortality. In the hydroxychloroquine group with a Z-Pak, 23.8% mortality. In the chloroquine group only, 16.4% mortality. And then the chloroquine with Z-Pak was 22.2%. So the data actually indicate that if you add azithromycin to these antimalarial medications, you actually get a worse result, right? So they were unable, their conclusion was they were unable to confirm a benefit of using hydroxychloroquine, chloroquine, or those with a macrolide antibiotic during COVID-19 treatment within 48 hours of diagnosis. The primary study outcome was hospital mortality. So all of these people were hospitalized and they looked at the mortality, how many of them died while in the hospital. And the other thing they talked about was cardiac toxicity. Okay, and so those two antimalarial drugs are known to affect the electrical, or may affect the electrical activity of the heart through blockade of the potassium channel, which is what starts the action potential for ventricular contraction. Okay, so SA node to AV node down the bundle of His to the ventricular muscle has to do with potassium channels. Hey, Jeff. Okay, it's evidenced by a prolongation of the QT interval on EKGs. Okay, and the arrhythmia is that they're worried about is ventricular tachycardia and ventricular fibrillation, both of which require CPR. Okay, so it's like an end stage, you're about to die deal. Okay, and so it may be that people that are taking that who actually get infected, I guess, I mean they're carrying the load. So I'd say most of the people that have had COVID-19 are asymptomatic. They just don't know. They might have had a few symptoms, or maybe they had no symptoms. So there's and the asymptomatic transmission by the CDC's own most recent information is pretty minimal. So an asymptomatic person who has COVID-19 is not as infectious as a person who is symptomatic. And then they changed all the things about wiping down your groceries and surface transmission, et cetera. That's all changed. So I'm sure it's confusing to everybody, and it's created the big firestorm of who's right and who's wrong and all that. And so in their study, they were basically saying that there was independent risk factors for ventricular arrhythmia, specifically people that have COPD, chronic obstructive pulmonary disease, or congestive heart failure, or cardiac disease in general. So there was an uptick of arrhythmia in those hospitalized patients, but they all for the study. But they also talked about the independent risk factors. It's kind of hard to tell. I think they, it was a pretty well written study. Now I'm going to go to a different screen, so hopefully I stay on here. Okay, so in defense of this study, they say our study has several limitations. Okay, so they're saying this is a limited study. The association of the decreased survival with those treatment regimens should be interpreted cautiously. So they say that in the Lancet article. That's not what's happening. Everybody's interpreting it as this is the honest truth about what's going on with hydroxychloroquine and chloroquine. And they said, due to the observational study design, we cannot exclude the possibility of unmeasured confounding factors. Okay. So, and then it also says a cause and effect relationship between drug therapy and survival should not be inferred. These data do not apply to the use of any treatment regimen used in the ambulatory out-of-hospital setting. Okay, so remember, all of these patients were in the hospital and they had started this treatment. So presumably they were symptomatic. It wasn't prophylactic. It wasn't a preventive dose. And the other thing that's interesting, my former partner, Dr. Noah Williams, and me for that matter, have been talking about zinc. He talks about zinc with Plaquenil a lot. And apparently he was exposed to somebody who was COVID-19 positive, and he took his 7 to 10 day course of Plaquenil and upped his zinc to 200 milligrams a day and was done with it. That's kind of how he did it. Okay, as far as the ventricular arrhythmia, in this study they said we did not measure QT intervals, nor did we stratify the arrhythmia pattern. So they mentioned torsade de pointe, which we won't go into. And we did not establish if the association of increased risk of death in the hospital with use of the drug is linked directly to that cardiovascular risk, and nor did they conduct a drug dose response analysis of the observed risks. Okay, so that's all kind of interesting, I think. So they pretty much say, okay, hi honey. That sounds kind of funny, actually. So the people that authored the study basically pointed out their limitations, and so nobody's talking about that really. They're just saying, okay, here's this study. This is true. This is what's going on all over the world. Okay, so now what I'm going to do is tell you some alternative viewpoints. Okay, and I would mention this young lady's name. It's Elizabeth. I'm probably going to destroy her name. But this is from the Association of American Physicians and Surgeons. They've been around since 1943, and they basically represent doctors, especially in private practice doctors, way better than the American Medical Association. And they've been around, like I said, since 1943. And this woman, physician, is the past director of the AAPS. I think she's not currently, she's on their editorial board. And so this is an editorial. It is not a statement from the AAPS, okay? And her 2 articles that it's read, one of them was from May 19th, so fairly recent. FDA bureaucrat brags he blocked physician prescribing of hydroxychloroquine in early COVID-19. Okay, so she's not real happy with that, okay? And so basically, the director, or one of the directors at the FDA, or a bureaucrat from the FDA who's not a physician, knowingly and unilaterally countermanded the Secretary of Health and Human Services, Alex Azar, to block access to, so that, there's an emergency use clause for the FDA for using that regimen in the hospital, but not, they're blocking doing that for outpatients. So if you wanted to do a preventive dose, they've kind of sounds like they've kind of hoarded the doses for use in hospitalized patients. And so if you wanted to do what Dr. Williams recommended, or what he did for himself, is take Plaquenil plus zinc after he was exposed to a knowingly COVID positive person through his work. Okay, so here is world data on May 18th, 2020. Okay, so she shows this, how third world countries are faring far better than the US, where entrenched bureaucrats, governors, and medical and pharmacy boards are interfering with physicians' medical decisions, which is the reason, for the most part, that I left medicine, is interfering with physician medical decisions. So I got in a big fight with the Oklahoma Medical Board about getting people off of Xanax, the ways that I did that, and they didn't like it. And I wasn't going to fight that fight anymore. I'd spent 7 years fighting with them already. Okay, so here's the countries that are using early and prophylactic Plaquenil. What I don't know is if they're using zinc. So I'll keep looking. India, 101,261 cases with 3,164 deaths, 2 deaths per million citizens. Okay, so this is in the percent death. They're giving you deaths per million. Costa Rica, 866 cases, 10 deaths, 2 deaths per million. Australia, 7,068 cases, 99 deaths. So this is early. So these are in people that were put on Plaquenil or chloroquine early and as prophylactic measure. So Australia, 7,068, 99 deaths, 4 deaths per million. South Korea, 11,078 cases, 260 deaths, 5 deaths per million. It goes on. Brazil is 255,368 cases with 16,853 deaths, 79 deaths per million. And then we're going to compare this. This is early and some prophylactic use in Brazil. And then the United States, based on that FDA bureaucrat saying, okay, we're not going to allow this use of early and prophylactic Plaquenil or chloroquine. So in the United States, it's used late in hospitalized patients. Clearly not everybody, because Dr. Williams treated himself. Okay, number of cases, this is May 18th, so it's gone up. 1,550,294 cases in the US, with the number of deaths at 91,981. I think we are close, if not have just surpassed 100,000 deaths. And the deaths per million in the US, 278 deaths per million, compared to India using prophylactic Plaquenil at 2 deaths per million. Okay, so that's kind of eye-opening, I think, because what we don't know, and like I said Friday, is numbers. Okay, we don't have randomized, double-blinded, placebo-controlled studies yet. There's no way to do that. It's going to take a while, but we do have reports from all over the world that kind of counter to what the Lancet published, because that's not early and prophylactic use. That is, you've been diagnosed with COVID-19. We started you on one of those 4 regimens, with or without a Z-Pak, and then that's what they reported on 96,032 patients from 671 hospitals from 6 continents. I did not look up how many hospitals are in the world, but that's the sample size is 671. And then when I told you I will put up the link to this, it's called A Compilation of Evidence on Hydroxychloroquine and Azithromycin in Treatment of COVID-19 and Breaking Results from Antibody Prevalence Studies. And it's got this huge list from all over the world of little teeny, maybe some teeny studies. I guess for the most part, you don't have, the Lancet has 96,032 patients in their study group. Nobody's close to that, at least what I'm seeing on this one. But it basically talks about, here's a randomized, non-randomized prospective study in Sao Paulo, Brazil, 636 symptomatic outpatients. So it just goes through all this. Randomized controlled trial in China of 150 patients. And it goes on, there's 25 pages on this compilation of evidence on treatment of COVID-19 using hydroxychloroquine and Z-Pak. So that's what they're doing. And it's from medicineuncensored.com. Okay, And that's where the updates are, www.medicineuncensored.com. Okay. She also, the AAPS editorial doctor, talks about a tale of two drugs. And I think I told you Friday that Dr. Williams had mentioned that from the FDA's own data, the risk of a cardiac event or a side effect or that arrhythmia or the torsade de pointe is 1.1 incidences in 1 million prescriptions, not doses, prescriptions. So, most of the people that take this are either, doing prophylaxis against being in a malarial area, or they're using it for lupus or autoimmune disease. So there's plenty of people, patient of mine that contacted me a couple of weeks ago. One of the things I asked her was, are you on Plaquenil? And she is, because she has systemic lupus. So she's very well versed in using Plaquenil, doesn't have a problem. There's no recommendation prior to starting someone on Plaquenil for malarial prophylaxis. There's my Missouri accent causing me trouble. Malarial prophylaxis or for autoimmune disease. Nobody has to have a baseline EKG or cardiac workup, et cetera, et cetera. So the insinuation, or the idea behind the article that she wrote in the AAPS online blog is that these decisions regarding remdesivir versus hydroxychloroquine are made based on money, of course, right? And then Dr. Williams pointed out that the people that are making, of the 11 people on the panel that are making recommendations on remdesivir and whether or not it should have emergency FDA approval, 9 of those 11 have financial interests in Gilead, the maker of remdesivir. So that's kind of a problem. So she said 9 experts on the NIH COVID-19 panel recommending treatment options have disclosed financial support from Gilead. So I don't know that they've invested in it or that they've been, it says financially supported. Okay, and she asked, why did these 9 experts not recuse themselves? Did financial conflicts of interest affect the recommendation against hydroxychloroquine, the older, safer, cheaper medicine? So remember, remdesivir 5 to 7 day course treatment intravenously is $1,000 per dose, plus the added cost of having to be in the hospital to receive it. You just can't walk down to Walmart and get yourself an IV dose of remdesivir. Whereas hydroxychloroquine has been off patent for decades. It's produced in China, India, Israel, and other countries, and it costs the patient an average of less than $10, so 37 to 63 cents per tablet for the usual 7-day course of treatment. So it's all interesting to me, and there's the facts to me. I think I fairly present both sides on that. Just some things to think about. So since it's Memorial Day, I'm going to make this a short one today. I'll be back Wednesday morning at 9:30, and maybe we'll talk about something other than coronavirus. Okay, so have a great day, and peace and health to all of you, and I'll talk to you Wednesday. See ya. Bye.